starting the recording. And Becca, you guys can see the agenda, correct?
Yes.
Okay, so I am admitting everybody right now. 123 are waiting.
Wow.
So it'll take a second for them to come in.
They want to wave to everyone.
Morning, everyone.
So I'm going to mute everybody and then unmute you guys again, okay?
Good morning, everyone. Thanks for coming. Today is our 5th town meeting, and to go over a little bit of housekeeping before our lovely speaker begins. We're going to try, during the presentation, please continue to use the chat box for your questions, and Dr. Holmes will address those when she's done her presentation. For the question and answer section after Dr. Holmes is finished, we would like you to use the raise hand feature. So if everybody goes down to the bottom of their screen where the gray bar comes up, you'll see participants and it says 137. If you click on that participant and find you see the list of people, and at the bottom of the list of people on your screen, it says invite, mute me, and raise hand. So you're going to click on raise hand. As soon as you raise your hand, it goes to the top of the page. So go ahead and try to play with that right now. I see some of you are doing that. Once you have your hand raised, if somebody else's question is the same as yours, you can lower your hand, and that way we know that that question's been answered. So go ahead and lower all your hands, please. And during the presentation, we're going to use the chat box. So at the bottom next to that participants was the chat. So if you click on the chat, you can see everybody chatting there. And you want to make sure your messages are going to everyone. So those are the 2 housekeeping bits. And without further delay, I'd love to introduce Dr. Breena Holmes, Vermont Department of Health Director of Maternal and Child Health. We are so lucky to have her here today, and take it away.
Okay, hi everyone, can you hear me okay?
Yes, and
okay, good.
You should be able to share your screen now.
Oh, I thought I was. Okay, let's see. Zoom. Give me 1 sec. Well, that's a bummer. Oh, Clayton, after all of our practice.
That's okay.
See if you want to. It was just up. I mean, I have it here. It's just not sharing. Let's see what could happen. That away. All right. So you're going to be in charge of the universe here.
Okay. Is that okay?
Mm-hmm.
All right.
Yeah, I just have to get you bigger. Let's see. So hi, everyone. While I'm fussing with this, I just wanted to say that I'm Breena Holmes. I am the Maternal and Child Health Director. And my background's pediatrics. I do want to make sure you know that those of you that don't know me, that I became a pediatrician because of my school nurse, who also was my next door neighbor, Mrs. Barker. And I have a lifelong passion for the importance of school nurses. I also wrote the national policy for the American Academy of Pediatrics on the role of school nurse with my beloved Ann Sheets, who is a school nurse in Massachusetts. So you're with a very safe and admiring person today. I think that your role in all things for children is paramount. I think your role in reopening schools is going to be the focal point of this whole journey that we're all on together. I also wanted you to know that we're living in a really uncertain time. It's so obvious to say, but I'm going to do my very best today to just get some information out and to see where it lands with you and where all the glitches and issues and pitfalls and barriers that you see ahead, because I know you're good thinkers and you're already having these dialogues with Sharon Lee, and you're really understandably concerned. So, but it's not going to be the best tons of answer kind of presentation, because we're in uncharted water, which you all know, but I have to say in every slide, essentially. Okay, next slide. I want to start with gratitude, as I always do. Clayton's in charge. I am so impressed with the way Vermont's pulling together for kids and families in this uncertain time. All of you have been involved already. You know, this is late news that you jumped in and you figured out a way to support your kids even in the absence of traditional education. So thank you, thank you. Next slide. I hope you found the health department website. We're so proud of this. There is a iterative approach to the way we show our data. If there's something about this data that isn't telling you what you wish you knew, I encourage you to email me, because we're changing it all the while. In the beginning, we didn't report pediatric cases. We now do by age 0 to 9 and 10 to 19. We still only have one case under the age of 9 in Vermont. I will tell you that we didn't prioritize pediatric testing. I know you know this, but it was, we had test supply concerns and we wanted to prioritize sick people and adults, and we did not encourage it until a week ago Monday. So now, 10 days ago, we put out a health alert to our pediatric colleagues, and probably symptomatic children can, we're going to see a big uptick in the number of pediatric cases, but there aren't symptomatic kids right now. So thankful for that, but that will change. But right now, end of April, not a lot of runny noses, partly because regular flu went away, partly because we're isolating, partly because, kids are not venturing out into the pediatric offices. So stay tuned on that. I have a lot more to say about testing, but I don't want you to see the data in a few weeks and say, oh my gosh, now we have an outbreak with children. If there are increased cases in the pediatric population, it's going to be because we're doing more testing. There's also some artifacts to the graph or the geography, that some of the big hot spots like, well, please be careful about the term hotspot. It's not a hotspot, but the increased cases in Chittenden and Brattleboro counties, that's about long-term care facility testing, and it does not reflect something unique to the general population. I could talk a lot more about this dashboard, but have fun with it. And next slide. I also said this already, but please know everything I say today could be wrong tomorrow. I do a lot of calling people back and saying, I misspoke. I said something that changed. The CDC changes its recommendations almost every day about different aspects of the response. Next slide. Okay, there is some language that's important and some changes. Many of you were involved with this at the very beginning when schools were still open and we were trying to figure out who goes where in the world of isolation and quarantine. I did want to remind you that the words matter and that isolation is someone who's sick. And if you have some symptoms and you're not sure your status, you should be isolating, and you should be doing that as well if you're waiting. But quarantine actually means that you're not sick, but you're around someone who had the virus and you feel you should stay home. These words don't matter so much during stay home, stay safe, because we're all staying home anyway, but I did want to be clear that if you're out and about and doing some work in your schools and wearing your mask and supporting your kids, that you shouldn't be doing that if you've been in contact with someone with the virus. That you would need to quarantine. It's also really important to note the CDC early on in this outbreak made decisions about who can go back into the world based on symptom recovery. And that originally they said you go if you have the virus and you go 3 full days without the fever, and that you had 7 days of feeling good, you could go back to life. They've changed that to 10. And I will tell you, because we have a lot of experience with testing, there is repeat testing going on in some facilities because people were a little unclear, should you just go back to work when your symptoms go away like this? And so we've been retesting people in some facilities like long-term care and corrections, and everybody's still positive after 14 days. So the test is not turning negative because the little teeny RNA of the virus is existing still in your body. So we're not using testing to send people, to keep people out or sending them back after they've already had the virus. Lots of nuance there. Sorry for all the language. Okay, next slide. I did want you to know we're in phase 2 of this outbreak response. I guess that's super hopeful. The way we were able to get to phase 2 is because we went 14 days without increasing cases. We're now on like 22 days of down. And maybe you noted this yesterday, we had no cases. Everybody that says that adds all this caution. Of course, we need to add caution, but I also think it's hopeful. What a balance between caution and hope, caution and hope. We also needed to wait to get into phase 2 to prove that our hospitals could safely treat everyone that needed it. And boy, did we do that. At the peak of this, back of about 3-4 weeks ago, we had a maximum of 17 people on a ventilator in the entire state of Vermont. I mean, that's just unbelievable for what we thought was coming. And I don't have a ton of answers why we did so well here. I think we need to be careful not to be too, high horsey about it, but we certainly were out ahead of some of the other states in our country. We have to really be able to test a lot of people to get into phase 2 so that we can contain the virus and those that have it. And we have to have active monitoring of the confirmed cases, which is called contact tracing. Next slide. So I think you guys went over this with Sharon Lee, so I'm just going to do it really quickly, but obviously the long-term goal is that we can get back to some life and we can lift some of the distancing measures, get people back to school and business. And we have to always do that with data and make sure we're not going to backslide. And you do that by contact tracing, but you also do it by, what? Hello?
I was just muting some folks. We should.
Oh, can you still hear me? Let me know if you can't hear me, Clayton, because it might glitch. Thanks.
No, I will. You're good. Thank you.
Okay, so we have to be very vigilant about the distancing and teleworking and facial coverings and hand hygiene. And I think this is going to get weird for people when it's a new normal. And I know healthcare professionals will be fine with it, but others are really resisting number 2. The vulnerable populations in our country and in our state are still going to need different rules about how they move about. And this is going to have huge implications for your population of kids with special health needs in public education. So stay tuned. Therapeutics are coming. I hope you heard yesterday, the FDA is approving some drugs. I have waited for this for weeks. The first step in containment and the hospital system is ability to treat people with this virus. And I'm really happy to hear some things are working in controlled trials. And then the immunity piece we're going to talk about in a second, super complicated. Next slide. Contact tracing is just what it sounds like. I know you understand this from Sharon Lee. If you have the virus, the health department calls you and asks you who you've been in touch with or what you've done with your life 2 days prior to your symptoms, and then when you were symptomatic before you isolated. What's really important for you all as healthcare folks is the health department team puts people into low, medium, and high risk category based on the level of contact. So this is super confusing because we only call the medium and the high risk contacts. So if somebody was in touch with someone in a grocery store and then that person tested positive, that you're not going to get a phone call. So this isn't a perfect, full, comprehensive 30-person analysis. It turns out about the average positive case in Vermont, we call about 3 or 4 people. But I will reassure you that we have adequate staff to do case contact tracing for about somewhere between 600 and 700 people per day. So if we need to, we can really call people. Next slide. Okay, and then you heard this yesterday, but here it is hot off the press. To stay in phase 2 and to feel really good about the understanding who has this virus, we're going to set a goal of doing 1,000 tests a day. Right now we do between 300 and 600, depending on if we're in long-term care facilities doing mass testing. The way we were able to get here is we have the right supplies and we have the right platforms. So we're going to start by doing much more testing, and this means people without symptoms in long-term care facilities and other congregate or group living settings like residential treatment for people in DCF custody, residential treatment for folks experiencing substance use disorders, etc. We also are going to use increased testing for healthcare professionals. We're going to start with healthcare professionals in the hospital and those that are going to be asked to come in for elective procedures. So that's next. I'm giving you a little preview for tomorrow. The governor always releases more restart activities on Fridays. So tomorrow I expect there'll be some conversation about elective procedures in hospitals. And then all the while we've been testing correctional facilities. But I wanted you to stay tuned on this with me, that in the coming weeks, we're going to be looking at testing other healthcare workers, including home health. And there was a mention yesterday of, should we have more opportunity for childcare to be tested? And as I say all the time, as goes childcare, so goes schools, because this is all one big workforce of people with similar exposure. What I'd like to say about this is between us, but also public, because I always do a little nuance. The opportunity to test folks like you and teachers and childcare providers will exist, but we have to be careful of what we're doing it for. It is a one moment in time test. A negative test on a Monday for a teacher is not reassuring for Tuesday. So there will be no relaxation in infectious disease prevention. There should be no relaxation in the way we think about being together with kids. The only thing testing does is it identifies a positive patient, worker, who should be removed from the caring. So obviously a positive healthcare worker goes home. A positive childcare worker goes home. A positive teacher goes home. So this is going to be very unusual. And I bet you're already asking a million questions about this. How are we going to use the increased testing to contain the virus, but not have folks think that this is some passport for immunity? Like, oh, good, I don't have COVID-19 and I can go back into my third grade classroom. So I'm just going to keep talking to you about it because it's messy. Next slide. So I think you guys are my scientific friends, so bear with me. We currently have 7 platforms that we use for testing in Vermont. The acronyms here are ridiculous, but the public health lab is the VDHL, and UVMMC is obviously the medical center, and then external are Broad and Mayo are 2 labs outside of Vermont. So NP is nasopharyngeal. That's the terrible teeny little swab you shove all the way back to elicit a massive gag. And nasal is just the front of the nose, and oral pharyngeal is just the back of the throat. You know, the old OP is the old strep test. So this is exciting. Many of you have probably followed this. We've been mostly just doing NP, but we're meeting this afternoon about moving to the front of the nose. So imagine how much simpler it will be to get a test off a kid or a elderly person in long-term care by just using the nares instead of the back of the nose. And then you see the turnaround. So most of the labs can report us within a day, but look at that there's a 3-hour test at UVM. They don't have a ton of those, but they use them for very, very sick patients and decisions about where to put them. The 1-hour test is the one, the 1-hour test, Cepheid, is the one we use for really sick people, but the Panther test we're using in labor and delivery. They're testing all women in labor because that's a high risk. There's a lot of secretions and nasal, breathing. And as you know, there would be some aerosolized particles in the normal labor process. So understanding women in labor and delivery needs a fast test. So much more to come on this, but I knew you'd be excited to see that some of this is getting really easy. Next slide. And here's serology. I hope you're following the news. Many, many states think are doing this right now. They think they should be doing blood tests for folks to see if you've had exposure to the virus. We had a work group 3 weeks ago with the smartest infectious disease doctors in Vermont, 3 adult doctors and 2 pediatric infectious disease doctors. And we decided that there's not enough accuracy and reliability in the serology test to test people for immunity, which is a bummer because people really want to know they had this and that they're protected for some amount of time. The problem with the test is it's not accurate. But the second problem is we don't actually know if you're immune today, how long you're immune. So again, it would create this artificial sense that you're good, or it could create the artificial sense you're not good, not protected. And then what are you supposed to do about that? So we just didn't start it in Vermont for individual decisions. We are looking to do a study of seroprevalence, which will help us understand the population's exposure, which is of great interest. And then there's also just an ongoing meeting of this group. So please know if a great test comes up that we can test people for antibody for the COVID-19, we're going to get it here and we're going to do it. But we're not confident yet in the accuracy of the existing tests. Next slide. Okay, and here's what happened, as I told you a week ago, Monday. We released a health alert to the pediatricians saying symptomatic kids should be tested. And we wanted people to focus on these subgroups of kids who were getting all screwed up in the what to do with them arena, people that were the children of people that were healthcare providers that were symptomatic. It was just getting complicated of should those healthcare workers go back to work. So we started testing kids. But as I showed you in the previous graph, they're not testing positive yet. And very few kids are symptomatic. Next slide. Okay, some of you had asked ahead to the questions to Kelly and Soph and others, what's going on in pediatric healthcare. I just wanted to give you the really quick snapshot because I'm so proud of my pediatric colleagues. This has been just the way you've mobilized for kids. This whole thing about how to deliver healthcare in the setting of COVID has been it's been beautiful to watch. I will start by calling out our health insurance people. Medicaid and Blue Cross Blue Shield stepped right up day one on this and said, we'll pay for whatever you need us to pay for to take care of these kids by telemedicine. And our Medicaid program did everything that was recommended by national advocates for children in the care of kids during COVID. So as much as we complain about payers, these guys were incredible. So our pediatricians have done almost everything by phone call and video, although they've done some pretty cool things for the kids that need vaccines and need exams. So they do what's called a hybrid visit, where they do everything by phone, and then they meet the kid and bring them in a safe way and do a quick height and weight and an exam and an immunization. We heard of colleagues meeting kids in parking lots, doing exams in trunks of cars. Tons of practices have set up mornings as well care, afternoons as sick. There's been a lot of changing of the physical environments of our healthcare workers. All the while, we've been encouraging that all the testing be done outside of primary care. So many of you know that, but we have test centers set up all over the state. And even though pediatricians wanted to do their own testing because of the situational anxiety kids experience, we still needed we needed to preserve the protective equipment in the centers. And if we put it out in the primary care, we were blowing through it at a time when we were nervous about supply. So this slide is just to show you all the iterations and how wonderful our colleagues are. There is a lot of talk about what to do to restart. I think you guys will be super interested to know that a lot of the way they've been providing care they actually like, and so do the families. And this is my heart from my pediatric days. Think about how much is about advice over the phone and, uncompensated. So all those years of phone advice now has codes and a way to deliver healthcare through the telemedicine. And then those of you that work in middle schools and high schools, the teenagers have loved this. We have some youth voice in our work in Vermont, as you know, the Vermont Rays, and they've given us some feedback that it's good, but they also find it a little awkward to talk to people by telehealth. So lots to say here, stay tuned. We may keep some of this in a post-COVID world. Next slide. Okay, we just threw in a couple of the healthcare guidance for childcare because originally this was childcare and schools when we were still open. And then when schools closed, we kept it as the guidance for the emergency childcare. I would encourage you to spend a ton of time with this when you start having, or already for a lot of your questions about how on earth you're going to do this. Because many of your colleagues in childcare are doing it right now. for the care of essential persons. And maybe some of you are already involved in your school districts with the school-age kids care for essential persons. So I'm going to base the health guidance for reopening schools on this. So we've received some feedback. This is a little long, and I'm thrilled that it's long because it has everything in here, and it is not meant to be pithy or one-pagery. This is not a one-page story. So next slide, I'll show you a few of the highlights here. This will be, I can guarantee this will be a part of your life in the fall if schools reopen. When schools reopen, whatever modifier you want me to use, I will, because I'm super hopeful, but I'm not the person in charge of this decision. So let's just stay together on when, if when. Daily health checks. I know you're going to have a lot of questions about that, and you're going to need a ton of equipment, and we're going to have to set this up just right, but we're doing it in childcare right now with cloth facial masks, hand hygiene, temperature checks, and questions. Next slide. So on and on we go with childcare. Childcare is going to reopen before schools. So this summer, June, July, we're going to have to get more kids back to care because more people are going back to work. And I just had a meeting. I have a meeting about it almost every morning. It's a top priority of our governor. So in this conversation is the size of the group. You guys obviously can't go back to school until group size is much bigger than currently recommended. So, we're hopeful that soon it will be 50, because you may recall the steps that we needed for mitigation of the virus. We started at 200, 150, 10 for group size. Then we went to essentially 0, just go home, except the paradox, we said go home, except childcare open for essential workers, groups of 10. So group size, stay tuned, because that matters the way you structure your buildings. We do think that drop off and pickup may have we do a whole set of guidance around that now, and it might have to be true in the fall. And then there's been really difficult conversations about disinfecting playgrounds. So, and the CDC put out they have to, and I admire them, but they put out all this guidance that was hard to implement. And one of was cleaning playgrounds. So I'm on a national task force for public health in childcare. And this is the type of feedback we're able to give the CDC, like, oh, okay, we're going to clean the rungs of the swings between every time a kid, just common sense / best practice is the rule of the day. And the other part that's interesting is masking. We're not allowed to say masking. However, we're supposed to say cloth facial covering because we're preserving masks for healthcare people. Cloth facial coverings for children was sort of vaguely recommended in childcare in the CDC's guidance. And we decided in Vermont we weren't doing it. And we weren't doing it because we knew that kids were going to have their hands all over their faces and that there was going to be a lot of risk to the infection with coming in and out of that, rather than just washing their hands and keeping them without the cloth facial covering. I will tell you, as we think about opening schools, we're wondering what age of kid would be developmentally appropriate to recommend masks. If you have thoughts about that, share it with me. I certainly know that kids with special health needs, behavioral concerns, sensory issues, there's going to be a whole weird, messy muddy pond about what to do with cloth facial coverings. And of course, food prep and meals is paramount. Next slide. Okay, so you guys have given me great feedback already through Sharon Lee and through your leadership that you've got a million thoughts on this. Do we have enough nurses to staff our schools? Of course you know, because I wrote the national policy statement, we need a nurse in every building. I offer that up to you again as national policy that Vermont gets closer to than other states, but we're not there. So I have your back on this. We need a nurse in every school. And I'm sure your next question is, where are we supposed to, even if that gets, pushed through and administrations agree and pay for it, what about just workforce? And do we even have enough people in the state to do that? I don't know. So some of you have fed back about the physical spaces. This made me a little sad, but I knew it was true that many of you function without the proper physical space currently to care for kids, both for the hygiene concerns and the sinks, but for the isolation of sick kids, especially with this virus. But, truthfully, a lot of the infection control measures we need to have in place this fall are the ones we should have had in place all along. And this might be our opportunity. And I need you to be very specific about the equipment and the setup of your physical space. I completely understand the supply issue. We've been working with it with childcare. You're not going to do this without adequate cleaning and hygiene and PPE. We do hope that people understand the difference between true PPE, which is really the masks and the goggles and the facial shields and the gowns that we need to preserve for people in healthcare settings, and what we'll need you to have, and then what do we actually just mean gloves and facial covering. And the nuance there is that I need you care for kids with suctioning and aerosolized particles and nebulizers, and that there is a subset of the care that needs true PPE. So stay tuned on that. And then, as I mentioned before, there's this ongoing national and state conversation about special populations of children and the reopening of schools. So this is the slide where I tell you that we're here for you. We have to try to get back to school, but we know it's not going to be easy. Next slide. Okay, a couple other resources. I'm almost done, I promise, because the questions are going to be the most important. The health department is working hard to have the right resources for you and others that care for kids and families. We're worried about increased child abuse. We created a child safety document, all available on our website. We're working with Department for Children and Families. We know that we haven't had enough eyes on kids during this isolation, and we're doing as much outreach as we can, but we're worried. Stress, stress, stress. You guys probably have way more resources on this than we could provide, but this is an unprecedented time and people are really struggling. Suicide prevention, we've worked with DMH on some messaging. I did want to make sure you all know that the media gets out ahead of things without data sometimes. And we at the health department, if we're one thing, we're data driven. And please call us if you hear something and want to message it, because it's not always true. That there is not an increased number of Vermonters and suicide in March and April in 2020. It's actually the same, if not less, than 2018 and 19. So it's a little bit of a sensationalism thing that we get going when we're in crisis. Domestic and sexual violence is also super on our radar and a deep concern in times of stress and also isolation. Next slide. And then this is more just an iteration of how we think about kids and their emotional lives during the pandemic. Next slide. Okay, this is the real down and dirty slide. I want you to know the CDC thinks it's going to be able to tell us soon. This is if you could see my thing, soon in quotes, about reopening schools, and the American Academy of Pediatrics is trying to do their own guidance as well. My old friends at the Council on School Health. You may know, many of you know, the Council on School Health has liaisons, and their number one liaison is the president-elect of the National Association of School Nurses. So the Council on School Health and AAP is not going to do this without the school nurse voice. The CDC also engages with AAP and school nurses. So I'm just super curious about these two documents and who's informing them. So I've got a little bit of an insider thing going on there. I'm trying to talk to my people, but everybody's moving really quickly. And then we wondered about, when should we get AOE and the superintendents and the school boards and you all and us together? How should we do it? Should we do it way ahead like this? And who should convene it? And how do we set an agenda? And I just don't want to act like I'm in charge of the universe, which I sometimes do. And I also don't want to do this too late. So part of the reason getting together today is to make a plan about that next step. Clayton, next slide, please. Almost done. I did want to do, this is a Sharon Lee analogy that I love. I'm super concerned to hear that you're not at the table. I don't even know what table I mean, but I assume there are planning tables in administration in schools, probably mostly about the distance learning and maybe the transitions. But Sharon Lee says something cute like, if you're not at the table or if you don't have a chair at the table, then bring your own chair. I think what we want to really support you on today is figure out who's meeting and just get yourself there. I can also do that at the state level, and I talk about it all the time, I promise, but I don't know that that's as effective as you asking your principals and superintendents to please not have one meeting about reopening schools without a nurse at that table. And this is the school nurse leadership that Sharon Lee and the VSNA that you guys have been promoting for decades here, and this is our time. School nurse leaders need to be at the table. I also love, and this doesn't always work, but there are great examples nationally and state. When you have a pediatric champion on your team, you bring them with you, or go meet with your pediatric champion and make sure that you are sharing the same set of sort of concerns and priorities as it relates to this reopening. And then we're right here with you, and we've got all these professional organizations working on it, like at the same time, essentially. Okay, next slide. I think we're done. Oh, just that this is an interesting, the Department of Labor created this quick training. It's actually just slides. It's not even narrated. That is for businesses that are going back to work. So if you wanted to take a look at that, it's really not going to provide too much information for you, but I did want you to know it's out there, that community folks that are going back to work, landscapers, all the way to hairdressers, are going to be asked to look at these slides. Next slide. It's available. There's the link. There's our awesome Sharon Lee, all cloth facial covered up. And I know that she's already been there for you, but she's not going to leave you. She's here through this journey, and she's doing a really nice job trying to figure out what the high level, medium level, and micro questions are, and how to get answers through the public health perspective. Next slide. Oh, just a fun, we love our website. Did you know we have a chat bot where you can go right in and ask your question? And if it doesn't have an answer, I have no idea how this works. Please don't ask me. But if they don't have an answer to your question, they put it through some filter that will help figure it out. So if you ask a ton of questions about things, it starts to create themes, and then we add it to our frequently asked questions, which is a really rich resource on the website. There's also a school and childcare page. I think you already know that. Okay, next slide. Yay, we got there. Okay, well, I'm not sharing. So Clayton, I'm done with slides, and I'm happy to start. Oh, there, hi. I didn't see you before because I had the silly screen up. Okay, I'm ready. How do you want to do this?
I can read you some of the questions. I've been copying and pasting them into the agenda here. So the first question was, what was the reason for testing of the first pediatric case, and what symptoms did they present with?
Oh, that's a great question. So I don't know the specific first, but I know that do you guys know what MMWR is? The Morbidity Mortality Weekly Report from the CDC. I can send you this. The first week of April, they did a specific analysis of all the kids in Seattle they're way ahead of us, right? And in Seattle, 56% of the kids presented with fever. That's all. I don't really know how to tell you this without the good and the bad news. And then another like 60-something% presented with cough. So we're checking for fever as a health screen. It's the best we have right now, but it's not an absolute. So this is a messy, messy virus. So fever's not absolute, cough is not absolute. And some of the kids were tested in the context of asthma, and some of the kids have been tested because they just had a bad cough. But and then there's a little bit of, there are a few kids who got tested because someone around them had it, but we still only have this little handful in Vermont, so it's not a really good data set. So I'll send you Seattle's data, and you can, I think it's going to be interesting to you in how imperfect it is. Yeah, so I guess I'm safe talking health with you all, but I think people like these hard lines like, oh my God, everybody with COVID has fever, and it's just not true. And I have another weird job, which is I have to call some of the test results in to people in corrections and long-term care facilities just because I'm a physician in the health department. And so I talk to those folks about their symptoms because I'm just curious. It's all over the map. But the primary thing people tell me when they have this virus is they feel constriction. They feel a tightness in their chest, like a weight. And then that nose thing is real. The loss of smell is real. I'm sure you've read about that. I poo-pooed that at the beginning. It's real. Not a huge percentage of people, but it's a thing. Does that answer it?
Yeah, that's great. The next question has a statement first. I know a nurse in another state whose employer requires 2 negatives. She tested negative the first time and positive the second, and she gets retested the next week, and this has gone on for 8 tests.
Yeah. Okay, I know a lot about this. We're never going to do that here.
Okay.
So here's like that. The CDC first said there's 2 ways to get back to work. You can do symptoms or you can do retesting. And that was sort of a choice. Which path? Do you want to do symptoms or testing? And the testing has turned out to be super problematic, like you just described. Everybody's still positive, and then, or they're positive, then they're negative, then they're negative and positive, because this is a PCR test, you guys. You know that the little RNA, which is just a teeny particle of the virus, is what gets put out on the gel to see if it, now I'm being too scientific, but it lines up where we know this virus has its lane in the assay. And so just a speck of it will cause a positive test. So it is not, so Vermont's done retesting. We're using symptom resolution to go back to work. And remember, I just told you earlier on, in these slides, it's now 3 days no fever. And when we say no fever, we mean you haven't masked it with Advil or Tylenol. And it's 10 days of feeling great. And then you go back to work with no test, which isn't perfect, but that's what we're doing.
So are the recommendations confident that people are asymptomatic and cannot spread the virus?
No, we're not confident. I mean, this is where I told you at the beginning. You spread the virus when you're asymptomatic at the beginning. We know that. And that's why when we find a positive case in Vermont, we ask people where they've been 2 days prior to their symptoms developing, which was not true in the beginning. Remember I told you we had to call people back and say we said the wrong thing? We told everyone the day you got a cough is day 0, and now it's 2 days before that. Once you've been through the whole virus, though, it's less spread, but it's not 0. So this is an almost impossible, I guess what I say to my childcare provider colleagues, I talk to them all the time. The safest thing to do is to stay at home until fall of 2021, until there's a vaccine. But that's not how we live in times of influenza. That's not how we live. It's not a functioning society decision. So we just keep guardrailing and guardrailing and guardrailing this virus, and we're getting so good at it. I feel so much better today than I did at the beginning of April. We understand it, we're testing for it, but we're still releasing people back to their jobs without perfect anything because we don't have the immunity confidence from this serologic test. When you have hepatitis B, you get the test that shows you have immunity, you're done with hepatitis B for life, but not this virus. So I'm so sorry to say that, but you'll hear a lot about this immunity passport. This is an ethical thing and an equity thing too, by the way. So if we start labeling people as safe and unsafe in our society, we're going to be in a place none of us want to be, because it's too nuanced. So we just have to wash our hands, not touch our face, work hard, keep the vulnerable safe, and then get this vaccine and go back to life. Okay, next question, sorry.
So the next question That's okay. The next question is, will school staff be tested prior to school opening in the fall? Will school nurses be doing test collections on teachers? And how will students be screened prior to school reopening?
Okay, all great questions with no answers. So we'll be giving opportunities for people that work with kids to be tested, but there's no mandate here. This is not a thing because it's a one moment in time. There will never be health department recommendation that everybody gets tested. It will be discussed and offered, and as long as we understand what we're doing, we might have it be that everybody should get a test. I don't see the nurses as being the person to test teachers because our primary driver here is the medical home and an order from a physician that a person needs a test, because we can't have it be population driven. You can't it's not the kind of test where you just, at this current moment, that you just do it yourself. I will tell you that there are tests in development to do it at home, the way you would test your sugar. Which is, I can't really imagine that world, but it might be coming. But you're not going to hear from the health department that a school nurse role is to get all the teachers cleared, because there's no clearing. That's one day. Okay. But whether we want to do some sort of population swath in late August to say, who are the professionals that currently have this virus, and we want to know that so they don't come to school day one, maybe. I mean, I've really been back and forth with the childcare recommendation because it's a tricky path. But the governor and others wanted it. They wanted to test childcare providers or give them an opportunity to be tested. So you guys have to just stay with us on this, because I don't know. But we're never going to use it in the way someone described, that someone is like, you can't come back till you have tests. And we're working really hard to have it be a voluntary experience.
How will students be screened prior to schools reopening?
I think we're going to do health screenings in the morning. But I'm also recognizing that there's too many kids, and many states have taken a childcare approach that they just ask families to self-monitor before bringing a kid in, meaning do the health screen at home and decide not to come in. And because we had such small volume of children, we decided to not do that. We decided to do the health screen in the emergency care. The childcare providers wanted that. It felt good to them to have some nexus of control at the beginning of the day. But I was actually advocating to have it be that just stay home if you don't feel well. So I think for schools, we can have a similar back and forth on which works best for your populations.
Is there any talk of training school nurses to do contact tracing?
So currently we've got the workforce we need, but if you guys are, we actually have a small initiative going with medical students because they're idle. There's a group of them who are idle. They're not allowed on the wards, the third years. I can work with Soph on that. I mean, the group of you that filled out the Excel spreadsheet for the Medical Reserve Corps, that's within Medical Reserve. It was clear that wasn't just, ICU nursing. That was a group of professionals who could help with the response in general. I mean, we heard some terrible story that some doctor was asked to go work in a stockpile warehouse or something. Like, that wasn't ideal. Yes, I guess I'll say the answer is yes. I do think the health department feels very good about their current volume of humans that are available for contact tracing.
How reliable are each of the tests being used? Shorter turnaround is good, but is it as accurate as the longer turnaround time?
Yeah, great question. All of those tests I put on that slide have very validation studies all over the country, and they range from 88 to like 96% sensitivity, which is, remember, sensitivity is the ability to pick up a positive. And then the specificity is much higher, meaning it doesn't miss it. So there aren't false negatives, but I'm sorry, there aren't false positives. So people that are positive, but some of the negatives are not negative. That's what sensitivity means. So most people feel that's good enough, and the fast ones aren't less sensitive than the slow ones. They're just more expensive, and they have supply chain issues for the reagents and the extraction. So we can't just open the world up to the 45-minute test, because we have to keep looking at stockpiles. How many do we have? How much reagent? How much extraction? Such cool, weird stuff. You know, there are so many stories of how we get stuff here, and we're way better off than other states. And it's just organization, knowing who to call, knowing how to get a truck here. It's really interesting.
Is Vermont going to do prevalent serological testing with children of parents who tested positive?
Oh, that's interesting. No, if it's supposed to be when we do seroprevalence testing in Vermont, it's going to be adults and kids randomly in a study design way, not specifics, with the exception that we wonder if we should do a seroprevalence study of just regular population Vermont, kids and families, kids and adults, and do one of a certain subpopulation, like a long-term care facility. But it wouldn't be like a group of sick adults and their kids, no. The priority is to get into a place with tons of elderly folks and say, how many people in this building, what percentage have had this virus, right? Because that's where all the viruses, I mean, almost all.
So there's been a lot of discussion about summer programming, and if childcare returns, should summer programs also be resumed?
Definitely. So that's kind of intrinsic. I mean, what I'm learning is the governing bodies of entities is like a moving target. We work a lot with Child Development Division and their childcare leadership. And then we work a lot with Vermont After School. And then we're trying to get the AOE partners in place about all this. So they're at the table this week for summer. And the whole key to summer programming is going to be that group size decision. So watch the press conference tomorrow at 11. We never know what the governor has decided until the press conference, because he's a really good thinker. I don't know if you guys are following. He is such a good leader. I'm not a political person at all, but he is just measured and thoughtful, and he brings in all the factors and then he says something. So group size is next. And if we can do summer well in Vermont, we're going to need 50. We can't do 10. There's not enough resources. And then we're going to try to have guidance in the childcare reopening in June that will address some of the summer questions. I mean, I get the questions that are brewing, you can feed to me as well. It's about field trips and the pool. What about the bus? What about markers? Do kids need their own mark? You know, and I'm layering like pseudo public health with common sense, as long as we can have groups of 50. And we're really working hard to get kids into their summer experiences. Now, please don't ask me about overnight camp, because that's a whole other kettle. And American Camp Association is coming out with guidance on Monday, next Monday, the 5th, which I'm sure is going to have some CDC feeling of sort of vagueness, but kind of helpful, but maybe not. But sleeping overnight and congregate living in sleepaway camp is going to be harder. But we haven't pulled the plug on it. Some camps are decided not to open on their own, but some are waiting. A lot of people are waiting till the end of May to declare anything about summer.
Should we begin to make and accumulate cloth masks for each of our students, along with ones that we presently are making and distributing to food service daycares and local hospitals?
Yeah, I would love that. I think cloth facial masks, that's the one thing I know for sure, is we're going to need to wear them. I don't know what to do about kids, but the adults need them. And most kids, we're going to have to figure out a way to make it okay for them too. But we're going to have exceptions, and I'm going to be fine with that, because pediatrics is what I've been saying to a lot of people, and maybe you guys are the same way. you always have to live in uncertainty because people call you or they come in the office like, how does my kid have appendicitis? Maybe, probably not, right? So there's all this nuance to pediatrics and school nursing that we're going to do the best we can, but a kid with autism isn't going to wear a mask. And are we excluding him because of that? No. So I don't know if that's helpful and if I'm going to get in trouble for saying that, but yes, get yourself cloth facial coverings and make them really fun. And if you have volunteers or a grandmother, you have anybody that wants to make them cats and raccoons and just have at it. It reminds me of like the hats we make in the NICU, you know, for the premature babies. Like we should have buckets of these.
Mm-hmm. Well, what about staff that work with special needs students? Do they need to wear masks?
So we're trying to stay hardline on adults and masks because of it's really an altruistic decision about your potential to spread if you don't know you have it. It's not really about protecting you. You guys know that, right? Mm-hmm. So yes, but I'm also, I mean, it's a little bit like, what's a good example of this? I was thinking about this example the other day about breastfeeding. Everybody should breastfeed. It's really good for babies to breastfeed, but there are people who can't breastfeed. And I think that if there is a child with a special need that cannot have his caregiver or his teacher or with a mask on because they cannot process that experience, we're going to have to wiggle and wash the heck out of our hands and not touch our face and keep the distance. And do you see what I'm saying? Like, yeah, but try to set the absolute that adults wear cloth facial covering.
And then there's another question about cloth masks and concern for students with asthma or other chronic illness. Are there guidelines to support this?
There aren't guidelines, but we do know that do you mean it, well, so for adults, I think adults still need to try to wear them even if they have those diseases. But for kids that experience respiratory symptoms and feel short of breath and then have to have a mask on, you're going to be you're going to have to. So no, there are no recommendations. It's another kind of case-by-case common sense. Wearing masks is hard. You know, other societies have adopted that way better than we. Our society hates it. We make fun of it. We didn't understand it during SARS when we were watching our you know, citizens of Asian countries, and we see people in airports. It's not our thing, but it has to be our thing until the vaccine. I hate it. I mean, I'm just telling you. Yeah,
Breena, we have just another minute left. I'm wondering if you have time for maybe another 15 minutes to answer some questions.
I do not, but Sharon Lee's on. Sharon Lee knows everything I know. I'm so sorry. I got myself all compressed with, but can you want to put them all together and I can try to answer some of them in writing as well with Sharon Lee?
Yes, ma'am, we will certainly do that. Just so that all of you nurses that are listening in, all of your questions on the chat have been captured and we will make sure that we get answers and we'll post that on our website as well. Also, Dr. Holmes has graciously offered to come as often as we want her to come or as often as we can fit it in. Obviously, we can't have her all day. Also, I'd like you all to know that some of the things that are coming, that many of your questions about return to school, as you know, we don't have those answers yet, but it certainly sounds like at the national level, all the appropriate players are making those recommendations. And we, as the Vermont State School Nurses Association, will continue to interpret those and identify guidelines for returning to school here in Vermont, recognizing also that that's going to continue to, we won't have any hard and fast rules in the next week, and we'll probably continue to be making changes even as school actually opens, whatever that's going to look like. So Breena, thank you so very much.
Oh, you're so welcome.
Truly
just in between
it.
between when we talk again, please figure out your administration's current meeting structure and make sure you get invited to those meetings. That's not even true. Don't get invited, just show up. I can't imagine a world where you're not at that table. So I'm frustrated, but I'm messaging that at the, state level, but I'd rather it be done at the local level. So
I think
State,
that
keep
I
me posted
appreciate
on
your
that.
support for us in that respect, because it makes no sense to me. Why is the school's health professional not sitting with the school decision makers?
Well, and it's just maybe
Talking about a
today is
health
the
issue.
catalyst for that, because you can say, I mean, maybe just blame me. Say, we had this great town hall with this lady, and she said, these decisions can't be made without me, so I'm coming.
She said, you're crazy not to have me here, so here I am.
Yeah, and I get that doesn't work for all personality types and those of you in different stages of your career, but we have your back. Like, you're my workforce. The school nurses are the key. So let's do it.
Thank you again so very much.
Welcome. See you soon.
Thank you.
so much, Breena, for coming.
Those of you that are still on, I just want to share with you again that we will capture all the questions in the chat. We will get answers to those for you as soon as we can. Today's presentation will be posted on our website very soon, as will the minutes that we've been taking, so that you'll be able to see the written capture of what has been talked about, as well as the answers that Dr. Holmes gave to the chat questions that have been answered today. Again, I can't thank you enough for all of your questions. These are questions that everyone is thinking about, wanting to know. And as this group, we had about 160 or more people on this call, which has been amazing. We will continue to meet, so we'll be meeting again next week, Thursday, 9:30. I want to share with you also that the National Association of School Nurses had an emergency meeting and made a very difficult decision to cancel the in-person National Association of School Nurses conference that is scheduled for the end of June and the first part of July. That will be offered as a 100% virtual conference. This means that many more people will be able to attend. If you have already registered for the conference, you will be getting an email directly from NASN, because the price of attendance at a virtual NASN is less than the price of the attendance in the physical. So think about that. If you had not registered to go, think about registering. There's a significant cost savings if you are a member of the National Association of School Nurses, which would also make you a member of our Vermont State School Nurses Association. The information that you will get is amazing. These are top level, absolutely phenomenal nurses that will tell us like it is. It is amazing. Also, can I share that news that you just shared with me, Clayton? Are you ready for this? The president of the National Association of School Nurses will be speaking to this group next week, Thursday, at our 9:30, 10:30 meeting. We are very excited to be able to do that. So set your alarms now to make sure that you tune in next week. And please continue to send any questions that come up between and whenever. Send it to the COVID-19@vssna.org. The four of us on the executive committee get those questions, so whenever we have an opportunity to be together, we are able to address some of those. Some of those we'll put off, but some of those will also guide us in what other speakers we need and how we can guide the speakers and the information that we're getting to make sure that we get it out for you. So again, thank you very much for your time, your commitment to the students, and your commitment to your fellow school nurses in this state. Very much appreciate all that you do.